Hello, everyone. Welcome to my rebuttal response to Shanna's presentation of the pro side of the conversation about whether provincial regulatory bodies for healthcare professionals should be replaced by national bodies for registration of regulated providers. A summary of my arguments is as follows: the possibility of inequities, a one size fits all approach, and increased bureaucracy and inefficiency. Shanna, I appreciate your thorough and thoughtful post in favor of nationalizing bodies for registration of regulated providers. I will address all three of your arguments, which are streamlining processes and reducing costs, enhancing patient safety, and improving mobility of health workforce. I will begin with argument number one, streamlining processes and reducing costs. Speaking to streamlining processes, the literature suggests that processes, such as investigating patient complaints about providers, has worsened under the Australian Health Practitioners Regulation Agency, also known as AFRA, a nationalized regulatory board that used to be regionalized. Nowotny and Al note that the processes are, quote, both too slow and too complex to afford timely learnings now, and internal AFRA employees, the public, and professionals have all expressed concern regarding these new processes. With nationalization, AFRA has now removed medically qualified staff as those investigating complaints, leading to lack of confidence in the system and processes by both professionals and the public. Communication with providers and complainants throughout an investigation is now minimal, often leaving them waiting years for any news of progress or results. Shanna speaks to research as being important, which it absolutely is, and that a nationalized system may strengthen infrastructure for researching and data sharing. Even in the face of nationalization, the literature notes that there is a lack of sharing of information across health services, health systems, and health jurisdictions in Australia since nationalizing. Establishing and maintaining these data sharing systems would also be an additional cost for these regulatory bodies. When speaking to cost, as I noted in my original presentation, some registrants reported an increase in registration fees of up to 50% when AFRA was initiated in Australia. Shanna uses the cost of running the College of Nurses of Ontario as an example of excessive spending. However, data from 2024 notes that the College of Nurses regulates 127,000 registered nurses, 60,000 registered practical nurses, and over 5,000 RN extended class NPs. Costs for regulating this massive body of almost 200,000 professionals would understandably be high, and assuming the cost of running a national regulatory body would not be astronomically high is a hasty generalization. Shanna notes that a centralized registration body would result in a focus on critical priorities, such as staying current with standards of care and continued improvement and innovation. She speaks to the streamlining of processes with nationalization. The definition of streamlining is, quote, to make simpler or more efficient. However, a study by Adams in 2022, interviewing healthcare regulators in Canada, noted that many interviewees expressed concern that amalgamating into a national organization would not, in fact, lead to streamlined processes. One participant said that they worked for a large registration body and admitted, quote, it would take the large regulator a few years to make a change that the smaller one could do in a few months. Interviewees expressed concern that there would be a lack of innovation, nimbleness, response time, and ability to provide fulsome support to participants, alongside the commitment to protecting the public. Of note, AFRA has also demonstrated a significant slowdown in approval of things like standards of care and guidelines. Another example is that throughout the COVID pandemic, countries with national regulatory bodies were not faster at implementing changes in the ever-changing healthcare landscape compared to those with regional bodies. I will now address argument number two, enhanced patient safety. One of the main purposes of a professional licensing body is to protect the public. Shanna argues that centralizing licensing ensures credibility and enhances consumer protection and confidence in service quality. Your cited evidence to support this is from AFRA, a nationalized regulatory board that used to be regionalized. This source is inherently biased, as certainly they would be touting that their organization is an improvement to the previous system. Although the public can access professionals' information online, perhaps more easily through a centralized database, it's actually suggested in the literature that people are less inclined to reach out to a national organization to file a complaint compared to regional licensing boards. as the complaints reported to AFRA and the governmental complaint commissioners are fewer in number compared to when Australia had a regional licensing board. This may be due to the lack of presence of local representatives in communities for both the professionals and the public, leading to the system feeling far removed and inaccessible. This lack of complaints leads me to question whether patient safety is supported by the centralized system, as not being able to complain about healthcare services or providers can lead to a variety of negative consequences such as deterioration of healthcare quality, poor health outcomes, patient safety risks, and more if their providers are not held accountable and or provided learning opportunities and interventions. AFRA has also been criticized for a lack of transparency regarding their investigations and a failure to act regarding complaints. This does not speak to patient safety, credibility, or maintaining the confidence of the public. Argument number 3, healthcare mobilization. Shanna argues that nationalizing registration bodies will allow a healthcare mobilization for situations such as during the COVID pandemic. I could not find any evidence that indicated nations like Australia, with a nationalized registration board, or Canada, who has provincial registration, redeployed a significant number of staff to other geographical areas. Rather, both nations implemented projects like increasing and subsidizing training programs for healthcare providers, redeploying staff from primary care to hospitals or long term care, temporary registration for practitioners who had recently left the practice, and expanding the scope of medical students and nursing students. Allowing healthcare providers to work in any area of the country may also come with many challenges and concerns. Some healthcare workers could be poached by richer provinces who have higher wages or better benefits. Some regions may also have alternative certification programs or pathways that are well suited to local needs. For example, in Quebec, they allow college-educated nurses to practice as registered nurses. Nationalizing may affect the ability of these existing staff to retain their jobs or be competitive in their own regions. Virtual care is also something Shanna discusses as being easier for patients to access with nationalized licensure, as it is presently difficult to provide across provincial borders. Virtual care is not an ideal replacement for in-person care and may actually add inadvertent strain to our healthcare system. A study noted that people were more inclined to visit the emergency department after a virtual care visit as opposed to a visit with a primary care provider. In conclusion, although Shanna's arguments are reasonable on the surface, there are several issues with each of them that must be considered. Regarding argument 1, streamlining processes and reducing costs, a registration system that went from regional to national has noted flaws, including patient complaint slowdown, lacking communication between health services, increasing costs for registration, and slowdown of guideline development. Regarding argument 2, enhancing patient safety, people are less inclined to report to a national regulatory body, and there is less transparency regarding these complaints, which may lead to a number of negative consequences for the community. Shanna's third argument is that nationalization would increase healthcare mobilization, but during COVID, there were no major geographical redeployments in Canada or Australia. Allowing healthcare providers to easily move across the nation may also result in unequal dispersion of staff and risking existing staff being pushed out of their jobs due to competition. Changing our current regulatory body structure should be something not taken lightly, and we should look to others, such as Australia, for the challenges they have faced to anticipate what we may encounter here if we choose to enact this change.